some feedback on this talk, you can use that QR code to give us some feedback. So with that, we will get started. Part of the reason I asked if anybody was in the physical room, we have invited Nicole from the Los Angeles County Department of Public Health, and I'm not sure if she was able to make it or meet you all. I see that Mary Esther from the California Department of Public Health, one of our public health nurses, is on. And so I wanted to, if Nicole is available and around, we were going to give her some time at the end to talk to you about some resources. So if we're able to, great, and if not, then I'll continue to let you know or go through this. So that's me. Let's see, next slide here. So this is the intent of today was to talk about metals, lead, mercury, and arsenic. My suspicion is we're probably only going to get through lead. And part of the reason I say that is that I changed this slide, this presentation around so that it could be a bit more interactive. And so what we'll do is present some cases, and then there's some questions that are supposed to mimic board review questions that I made up. And so we'll go through those and give you all a chance to think about them and potentially respond. And then we can go through why those questions are right or wrong and so forth. I'll tell you that when you give a talk on Zoom, it is sort of disorienting because you can't see or know sort of how people are reacting. So please feel free to chime in verbally. I don't usually look at that little chat thing. So if you have a question, just feel free to chime in. So with that, we'll get started. So here's the first thing. No, there's no disclosure, nothing to disclose. I don't have any financial relationship with our commercial relationship with any of the things we're going to talk about, other than obviously I work for the University of California, San Francisco. So here's our agenda. I'll do a brief introduction of me. We'll go through some cases. We'll talk about the pathophysiology, do a brief literature review, and then go through some recommendations and leave some time for discussion. So just to give you an idea of where I'm coming from. So as I said, my name's Timur Durrani. I did my first residency in family medicine down at UCLA. And then I did a public health residency at the Los Angeles County Department of Public Health and worked for a little bit, and then came up to San Francisco where I did a fellowship in medical toxicology and worked for the poison control system. And so this is a picture of our webpage where you see one of our managing directors having his picture taken. And this is sort of what it looks like if you were to come up to our poison control center. Sometimes looks like kind of a 911 center where we're answering calls and so forth. So that's Dr. Ray Ho answering somebody's call. I also work for the University of California, San Francisco, and I work for something called the Pediatric Environmental Health Specialty Unit. And so you'll see our link down here that you're welcome to go to our webpage. We have some funding from the EPA and from the CDC. And what we do is sort of three main things. One is to train the community on things like environmental exposures and things like that. We also train clinicians like we're doing today, and then we'll also occasionally see patients. And so you're welcome to reach out to us through either poison control or through the Pediatric Environmental Health Specialty Unit if you have clinical questions and so forth. I'll tell you, most of the time we can do a lot of the clinical questions just over the phone. So it'll be one of us talking to one of you on how to manage a patient and so forth. But if you have a patient that you wanted to be seen, we can do that as well. Very similar to how things are done at UCLA via Epic and so forth with referrals. So one of the things we have up here is a lead clinic. And so what you see on the left is one of my co-conspirators, Dr. Allison Matsunaga. And so we have a lead clinic where we'll see patients who have elevated lead levels. And so Dr. Matsunaga is a hematologist, and oftentimes, as we'll go through, we'll see patients who have, let's say, anemia and things like that. And so we have overlap with hematology and with toxicology. The other reason that it's been helpful to marry up with Children's Hospital of Oakland is that the way things work in California with regards to payment for Medi-Cal and especially things like chelators and special medications is to be at a place that has the ability to bill for that and to get these things covered for people. And so we have our clinic there specifically at times so that we can make sure things like a specific chelator or a hospitalization is covered both by a specialist like Dr. Matsunaga, but also the medications that go along with these, which can be fairly expensive. All right, so here we go. We'll start with a case. So we have this is a patient we saw a few years ago, and it was a 3-year-old boy who immigrates from Afghanistan about a year prior, and he's completing his well child visit. He was completing his well child visit with Alameda County, which has a health program and nurse practitioners and public health folks who are also attending to that. He had generally a normal physical exam, but he was noted to have some things that were positive on his review system, specifically some constipation and anorexia. Um, as part of his evaluation, he got some routine screening laboratories, which revealed about 2 days later, which is pretty common. We get our results, a few days after this, where he's got some iron deficiency anemia and a lead level of 72 micrograms per liter. So here comes your first question. So what is your next step in the management of this patient? I realize we don't have any polling ability here, so feel free to either type in chat or respond. So what would your next step be? Would you request a repeat blood lead level, obtain a zinc protoporphyrin level, begin immediate oral and IV chelation, or order a kidney, ureter, and bladder X-ray? Let's see what do we have in chat. All right, so the peds chiefs say A, will request a blood lead level. Anybody else? Yeah. So sometimes looks like we have people live, so I'll stop and see if you guys have any thoughts or suggestions. Maybe not. Okay. So you would request a repeat blood lead level, and so as part of that, we get that and it confirms. So then we are bringing him over to the hospital because at that point his level of 72 means we probably need to evaluate him. So what you see here is the KUB, and this is a iPhone picture of a PACS screen, and so you may not be able to see some of the things that we want to point out to you. So this is the next picture is an up-to-date screen, a photo from up-to-date, which is a bit more clear. And so you see these things here, which are these radio opaque findings on his plain film. So now that we found these radiopaque fragments, what's our next step? Should we A, induce vomiting, B, administer some activated charcoal with sorbitol, C, initiate intravenous chelation with calcium EDTA, or D, refer to the hospital for emergency evaluation? Oh, lost that. So the answer here is going to be D, refer for hospital emergency evaluation. So why is A wrong? We generally don't induce vomiting about in any situation anymore from a poison control standpoint. We have other ways we had to get something out of somebody's stomach, but generally we're not inducing vomiting. Administering charcoal with sorbitol, for two reasons we probably wouldn't administer charcoal with sorbitol. First is that charcoal won't bind lead. Lead's too small to be bound by charcoal. And for the most part, we stay away from charcoal with sorbitol. Can induce some vomiting and GI upset and things like that. So if we're going to give someone charcoal in another scenario, we generally aren't using sorbitol. And then initiating with chelation. Anybody have any ideas of why we wouldn't start this person with chelation? We've got a high lead level. So the reason is they still have lead that's in their stomach or somewhere in their GI tract, and so we need to clear them and get all of that removed before we start that. And we may have another question on that later, so we'll expand on that later. So here is we refer them to the hospital. So this next thing, depending on how big your screen is, it can be a bit of an eye chart. But this comes from the California Department of Public Health and gives providers sort of a stepwise approach to children with elevated lead levels based on their blood lead level. And so what you can see here is that at a level of 3.5, there's some evaluation and management that goes on. From 3.5 to 9.4, you see things, you see that evaluation and management. And then again, from 9.5 to 14. This continues on. And so then we go from 14 to 19 to 44 up through 70. And so depending on where you have a child who has these blood lead levels, you have some guidance on how to do things like evaluate and management. As you start to get up into these higher levels, what you'll find is that you'll see things like consult with a physician who's experienced in managing chelation. Oftentimes, that's where we would get involved in a hospital setting. You might call a poison control setting. You might call your friendly neighborhood toxicologist. UCLA has attending toxicologists there with the toxicology fellowship, so you might talk to some of those folks. And then we at the Poison Center are open 24 hours, so you could call us. But once you start to get into these higher levels, these kids are hospitalized and may need, pretty acute care treatment. And so we are happy to be involved if you need us. So what happened with our kid? So he was being evaluated at Alameda County. He gets referred over to Children's Hospital, and then we have Poison Control and the Western States Pediatric Environmental Health Unit that are all involved. And so you can see that we have, sort of a health system triad and the availability to work with our colleagues at all of these different areas. And so that's what we do. And so as you see, as I mentioned, we have some of our public health nurse colleagues online, and they are a resource specifically for things like lead when we have a child who has an elevated lead level. And so we're constantly sort of in contact when we have a case like this, because we may have a provider at the hospital who's talking to somebody at poison control, who's also talking to someone at public health department. So it's a team-based approach and allows for sort of collaboration at multiple levels. So that's what we did for this kid. So what happens next? So day one, at about 6 in the morning, when this level comes back, Poison Center is called. And so then we notify the inpatient team and the Alameda County lead poisoning team so that we can all get sort of on the same page. And this is something that I think is pretty impressive that you don't see quite often, is that a few hours later, we have the Alameda County Public Health nurse who's out at the home. And they're out at the home trying to figure out what's going on. And they have a whole sort of protocol of trying to figure out where this potential lead is coming from. And so this is a pretty unique opportunity to be able to work with our public health nurses who get to go to the house and really evaluate where a hazard is coming from for a child. So it's a pretty unique and pretty neat thing that happens generally only in lead, unfortunately, but it's a nice resource to be able to have. So then what happens? So our public health nurse is asking about the use of something called surma, and I'll show you some pictures of that later. They replete the blood lead level, which is still pretty elevated. It's at 58. He gets we were able to sort of clean out his belly and so forth. So he gets his first dose of oral chelation. And then we start going down the nutrition assessment and recommendations, ideally to try and eliminate lead's ability to be absorbed into the body, or at least to help with minimizing its effect while it's in the body. And so by day 3, we find out from the public health nurse and environmental health assessment that there are a number of different places where this child could be being exposed to lead. The home was built in 1923. The paint has been pretty much containing lead for many decades, and there was lead found throughout. So I mentioned this thing called surma, which is called different things in different cultures, but you'll see children who will have what looks like eyeliner around their eye. Depending on where this is procured and made, we found that some of it has 99% lead. And so when we have 99% lead, it's particular for something that's so close to the mouth, we'll find kids who have elevated lead levels. We've had some programs where we'll have, through the Pediatric Environmental Health Specialty Unit, where we've gone out to cultural events and essentially we'll swap out the home country surma for things that are produced that are lead free. So we'll use things like eyeliner that we know is lead free. And so we'll do a one-to-one swap so that we can reduce these things. But if you go to our webpage, you'll find that we've got information on things like this in multiple different languages for different cultures who use these sort of eyeliners for cultural purposes. And this just shows, so what I showed you previously was just an MMWR that was going on, that was reporting on this. And then the FDA also had reported on things like they're called different things, surma or coal and so forth. But we'll find that kids have these exposures and can have elevated lead levels based on that. All right, so that's our first case on lead. So here's our second case. It's a 14, well, let me stop and see if there are any questions, comments, or concerns before we move to our next case. No? Okay. All right, so here's a 14-year-old male with a history of autism presents to his pediatrician's office where his parents complain that he's had a decrease in his appetite. They started giving him some Ayurvedic medications approximately 1 year ago in the hopes that it'll help cure his autism. On exam, he's really unchanged from his baseline, although he notes some abdominal discomfort, and he's had about a 10-pound weight loss from the year previously, sorry. His pediatrician gets a CBC, which shows a hemoglobin of 9.9 and a blood lead level of 53. And then we repeat that again, and it comes back at 53. So, it looks like we skipped one of our, oh, here we go. So here's a KUB, and you can see these two sort of radio opaque things that are coming from what we think are this Ayurvedic medication. So we go on to test some of this Ayurvedic medication, and we sent this off to the health department, who then was able to test these things and find that they had a fair amount of lead. So you see this lead limit that's been described, it's put out by the FDA, and this is for essentially food and medications, and so it'd be 0.25 micrograms per gram. But you're seeing that these things are in the milligram per gram, so they're pretty highly, have a fair amount of lead in them. So we take a picture of some of the stuff that they may be taking. Does anybody know what this is, what you're looking at? Looks like a table of some sort. So this is your sort of typical X-ray table that you would have in the emergency department. And so what we did was one of our fellows went and asked if they would just take an X-ray of this because we weren't going to do immediate testing. And so when they took the X-ray, what you find is you can find what's radio opaque. And so this sort of matched up to what we saw on the plain film. And so yeah, it's a sort of a quick and dirty way to look and see what's radio opaque as we're trying to figure out what sources may be and so forth. So we touched on this earlier, but true or false, chelation is an appropriate substitute for removal from lead exposure. So rather than removing them, we'll just start throwing meds at them and see if that'll get all the lead out. All right, we got two false. That's right. So it's false for a couple of reasons. the biggest reason is that our chelators can't really remove these things at levels that could otherwise be removed from just removal from exposure. And so if you look at when we are giving medications to remove this, we're removing this on, maybe milligram levels, it's, subparts of milligram levels, but may have grams of this stuff. And so what we want to do is remove this as much as we can, let's say from the gut, or remove them from exposure. And then if that doesn't suffice and we're at high enough levels, then we'll start to go down the chelation route. But for a variety of reasons, we don't chelate in place of removal from exposure. What we ideally do is remove from exposure and then determine if they still need to be chelated. Yeah. All right, so appropriate chelating agents include oral succimer, intravenous succimer, penicillamine, or sodium EDTA. Anybody have any preferences on which one of these they would use in a kid who needs to be chelated? So Peds Chief says D. Anybody else? Got a thumbs up for D. Okay. So the answer is A, oral succimer. The reason, for the most part, we use oral succimer is cost. Most places don't carry EDTA anymore because of cost, and I'll show you why later. But what you see here on A is the sort of general treatment regimen that we'll use. The issue here is that it's oral, so if you get to levels high enough where kids, are generally above 100 or so. Oh, sorry, I'm pressing the wrong buttons. Where kids are above 100 or so, they can be encephalopathic. And so part of the issue is trying to administer oral medications, which can be done and has been done. I'll show you some studies on that. And so the reason we use succimer is sort of really logistics and availability reasons. Intravenous succimer doesn't exist in the United States, so it's not an option. So we don't use it. Penicillamine used to be used. We don't use it for lead anymore for a variety of reasons. One of those being that it's poorly tolerated. But the other is that the issue here is that the dosing is off. So I have there 1 milligram per kilogram per day, but it'd be more like 20 to 30 milligrams per kilogram per day if you were going to use penicillamine. And then the last one is a big distraction. So that's sodium EDTA. It can sound like calcium EDTA. This is one that would be contraindicated because there have been a number of deaths around the use of sodium EDTA. They were reported in the 90s as a treatment for autism. If you look at EDTA, it looks, and on a sort of chemistry basis, looks like sort of a square where it's able to bind these divalent cations. And so what happens in sodium EDTA is that sodium will get released and then it will bind calcium. And so the reason we use calcium EDTA is that when calcium gets released, it will then not bind free-floating calcium, but bind free-floating lead. And so the sodium EDTA has resulted in profound hypocalcemia. And so we stay away from sodium EDTA and use calcium EDTA. When it's available. Let's see, I'm going the wrong way here. All right. So lead. So what is lead? So lead's a metal that is occurs everywhere in the Earth's crust. It's an element, and so it's sort of ubiquitous in the environment. What we have found is that it's very useful from an industrial standpoint, has been used in all kinds of things. It's abundant, it's cheap, it works very well for what it's intended for from an industrial standpoint. The issue is that it's not great for humans. Where is it? You can think about lead just about any place that you see things like pigment. And the reason being is lead is great from a sort of anti-corrosion standpoint. So any place that you would have pigment like paint or anything else would be a good place if you were using it from an industrial standpoint to include lead. And so if you're using, let's say, paint outdoors, that would be a place that you would find lead. And so the pictures that you see here are all places where lead has been found. And so these are things where we can find kids getting exposed to lead in a variety of different places. What you see up in the top left here is outdoor homes, an outdoor home that may have lead. And then what you see here is right next to it is the dirt. So that paint flakes off and that lead moves from the home into the dirt right next to it. And this will stick around. Lead's an element, and it doesn't really go anywhere unless you were to pick up that dirt and remove it. And so it's a place for kids to get exposed. And the variety of different toys and so forth can have different pigments on it. And then what you see on the right are, let's say, occupations that parents may have where they have the ability to bring some of these things home. And so that you see in this green here is this transfer of, let's say, lead dust as parents coming home and then transferring some of that. And so ideally best practices are people able to remove the clothes that they're working in before they come home so that they don't transfer some of this stuff home. But we'll see lead exposures in both, people who are doing this for work or maybe doing it on their own in the sort of DIY scenario. So depending on where you grew up and when you grew up, you were told there's some normal level of lead. And so what this looks at is what was considered sort of a level of concern, or sometimes people would say normal blood lead level. And so in the 1960s, a tolerated blood lead level was 60. And then over time, it's gone down and it was at 10, and now we have less than 5. And there's some movement in the public health world to get it to 0. And so the reason I point that out is depending on when and where you trained, you may have been told, well, a level of X is not concerning because that's what was considered normal at the time. The reason this has gone down so much over time is that from the 1960s to now, we've seen a variety of that we've seen the science evolve and show that lead levels are harmful on a population basis at just about any level. And so that's why we see that drop in what's considered normal. If you look at when people were born and look at the blood lead levels of women during that time, you find that depending on where you were, when you were, you may have had a detectable blood lead level. So what you see from women of childbearing age from 1976 to 1980 had a medium blood level somewhere between 12 to 15. It's like around 12 or 10 to 15. So, close to about 12 or so. After 1978, lead gets removed from a variety of different products. And so we start to see the lead levels go down in the population. But part of the reason I point this out is that oftentimes we will be asked about what is this lead level, if we have a child who has a lead level of 10, let's say, or a mom who has a lead level of 10, what does that mean for the future? And so, it's hard to predict the future, but one of the things we're able to tell them is with appropriate management, we anticipate that they, on an individual basis, should do okay. Now, it's different than some of the population level studies that we see. But the reason we point that out is that we know that there were people who were born in the 70s and so forth that had these blood lead levels either in utero or afterwards. And so we then focus on trying to minimize the impact that this has on their future. So lead looks a lot to the body like calcium. And so wherever calcium is, lead is. And so part of the issue then becomes is that lead can affect, you name a body system and lead can affect that. And so that's one way to think about this, because you'll find it in, we recognize it as a neurotoxin, but we can find it in just about any, affecting just about any other part of the body. And so lead looks a lot like calcium. And so when you start to then think about what does lead do, you can think about, just about any part of the body. This is an old but sort of useful key looking at lead levels. It's broken down into children and adults. Part of the reason it's broken down that way is that the literature is there's sort of two forms of the literature. There's pediatric version and then really occupational health, occupational literature. And so I point that out because we have children who will get exposed to lead for a variety of reasons, usually, between ages 1 and 2 when they're close to the floor, they have a lot of hand-mouth behavior and so forth. And then we have adults who are getting exposed from sort of more an occupational level. More recently, we've started to see adults who are being exposed from non-occupational levels and things like Ayurvedic medications or other things that have lead in them. And so you can use this as sort of a general guide of what do we see as we start to see these higher levels of lead. And so as we get into these levels above 50 and getting close to 100, we move from a kid who can be, generally managed as an outpatient in the 10s and 20s to as we get into, above 45 or so is where we're now going to hospitalize someone, try and remove all the lead, and then get them started on their chelation. And part of the issue with the chelation, as I mentioned, is it can be expensive. So oftentimes we're doing a variety of things in the hospital and then figuring out a number of discharge planning to try and maintain their chelation because this is going to go on for another few weeks and we're clearly not going to keep them in the hospital for that. All right, here's another boards question for you. So identify the red cell inclusions below. So is this a Howell-Jolly body, a basophilic stippling? These are just normal red cells, a Pappenheimer body, or this is Falciparum vivax. Anybody have any thoughts? This I suspect will be on some of your boards. Yep. So yeah, you got this right. You guys got this right. So this is basophilic stippling, which is pretty classic. This is a classic sort of finding in lead exposure, which is just aggregated RNA within the red cells. And so if you think from a board's perspective, lead and red cell inclusion, basophilic stippling, which is not unique to lead, but a finding that we see not infrequently with lead exposure. So oftentimes we talk about lead inducing, inhibiting normal red cell synthesis, which is true, but particularly when we see at lead levels less than 40, it can inhibit a number of sort of red cell development and enzymes and so forth. When we get into these higher levels, particularly in the kids who are like we will start to see hospitalized, they will also have be at risk for frank hemolysis. And so we're can be dealing with both sort of anemia from history of lead exposure and then frank hemolysis at the time. So it's something to be aware of as we start to deal with kids who are moving from the outpatient to the inpatient scenario. So true or false, the radiograph below indicates chronic lead exposures. Anybody know what we're looking at, first of all? So you see that sort of a normal bone, and then we see this pretty hyper dense area here. What do we term this? So this is something that's called lead lines, and it's not unique to long bones, although that's sometimes where it's an easy place to get a plain film. So this indicates chronic lead exposure because you'll see these sort of hyper dense areas. And so sometimes when we're evaluating kids who have an initial lead level, we can get a skeletal X-ray to try and determine if they have elevated, to try and figure out if this is a singular lead level, let's say, or if this has been going on for a while. Because part of what we're doing is trying to be detectives to figure out where is the lead coming from, how do we remove them from exposure, and so forth. So these are called lead lines, and so these are pretty common. And you can see that they end up affecting the growth plates and so forth. So true or false, these radio densities seen in lead lines are composed of calcium. So what are you seeing there? Is that calcium or is that lead depositing in the bone? Pete's Chief says lead. Anybody else? So this is actually calcium. So what happens is as lead mimics calcium throughout the body, it interferes with just about every process that can occur that is related to calcium. And so what we see is this sort of hyperaggregation of calcium in bones. And so when you see this thing called lead lines on a plain film, this is a sign to you that they have had chronic lead exposure, but what we see here is not lead, but calcium. So it's a little counterintuitive, but it's what we see. Um, so moving now to just some of the things that we'll see for people who are around lead, we find that there are different groups, people who, let's say, are either into firearms. So we'll have things like people who do shooting for sport. One of the things to sort of point out is when people are using these things, the gunpowder that's in there has something called lead styphenate in it. And so as they're using some of these firearms, they're getting exposed to lead fumes that are coming out when they're shooting these things. And so you can find these things all over the place, and there can be a transfer then when somebody goes from shooting to then going from where they were shooting to their clothes, to their home, and so forth. And then the other thing that we'll see is retained lead fragments. So this was an adult patient who had walked into a gun battle. And so these are lead pellets from a shotgun that were, this was a few years after she had walked into that. But she had these retained lead fragments from this gunshot injury, and she had a detectable lead level around 15 or so, which is not totally uncommon when people have retained fragments. And so the question then becomes, how do we ideally remove these? As you can tell, I think when we counted, there were something like 30 of these. And so as we were talking with plastics and ENT about removing them, the morbidity that was going to come out of the surgery to try and remove these was not insignificant. And so we had a discussion on the sort of risks and benefits of removing these pellets versus letting them remain and her having sort of a lifelong lead level that would be due to these pellets. There are some, for those of you who deal with gunshot wound victims and who have sort of lifelong retained fragments, there's literature looking at this. For the most part, what we find is that retained fragments, particularly as they are near sort of joints or maybe near CSF, tend to have higher lead levels because those are slightly more acidic, and so lead is able to leach out of that. And so when we find those folks, the issue generally tends to be removal because of the morbidity around trying to remove some of these embedded fragments. And so there are some people that we have had on sort of prolonged chelation to try and just keep the levels down, something like Suxamer when they've got embedded fragments that can't come out. And so this is oftentimes a discussion that we'll have with surgery to see if they're willing and able to remove them. And if not, then we'll manage them medically. So now we're going to move into a little bit of the history. Well, I'll pause and see if there are any questions or comments, and then we'll move into some of the history of lead. So this is Alice Hamilton. So Alice Hamilton was a physician and epidemiologist at sort of the turn of the century. And so she was known for her sort of, I think they called her sort of leather epidemiology, because she would wear leather shoes and walk around and look and see where people were being exposed to chemicals. She was, I think, was the first woman who was on the faculty at Harvard Medical School. And so she's well known in the environmental epidemiology realm. And so she was tracking people who were being exposed to lead at that time in a workplace environment. And so this has been sort of a known thing for decades at least. So why do we care? I've just been talking to you a lot about sort of individuals, but lead is something that's been pretty well studied in the epidemiologic and public health realm. And so part of why we care when we move from individuals to a population is it can have population effects. And so if you remember your sort of epidemiology thoughts and topics, we have this bell curve, sometimes described as a normal curve, where in the middle we have the mean, which is however you measure IQ, is described as 100 or normal for this bell curve. And then as you get further apart from the bell curve, you get your standard deviations. And so your mean here is 100. And so based on this population, we would have 8 million who are in the sort of gifted realm and another 8 million who are in some sort of intellectual disability realm, just based on this bell curve. Now, if we take something like lead and recognize that at some level it will decrease however you measure IQ for a population, you've just moved this bell curve over. So instead of having a mean of 100 now, we have a mean of 95. And what that means is we've now nearly half the number of people who would be in the sort of gifted realm, having these IQs at really high standard deviations. And we've nearly doubled then the number of people who would have some intellectual disability just based on the statistics of this. And so this is why, from an epidemiologic standpoint, from a public health standpoint, we want to try and remove as much lead as possible from the population, because it has even one decrease in IQ has pretty big impacts on a population. And so part of our role then is trying to take some of the information that we understand on a population and apply it to an individual. And so that's part of our role, is explaining that and explaining, taking each individual then and understanding what they have going on in terms of their health risk, health history, and so forth, and therapies that we can use for them as we translate from population to an individual. If you look at the epidemiology of pediatric lead poisoning, it's higher among inner city children, and it's increasing among refugee populations. And so in California, any child is eligible for lead screening. If you look at the CDC and the AAP guidelines, they recommend children who are in some sort of government assistance. In California, that's not the case. Part of the reason is the housing stock in California is so old that just about any child could be in housing stock that's pre-1978, so they are eligible for blood testing. And so that's different than other states where it may not be covered from a cost perspective. So any child in California can be screened for lead level, and it should be covered at ages 1 and 2, or anytime you have concern for potential lead exposure. So why do we care about these levels of lead? You may have heard at times that for every increase in level, for every 1 unit increase in a level of lead, you'll see a decrease in your IQ or development score, or however you measure that. And that's generally true at 10. And so there are a number of these papers that you can look at that as you go up in blood lead level, you'll see a 1 unit decrease in IQ score, development score, and so forth. The issue is at levels below 10, it's not a 1-to-1, it's a higher ratio. And so if you look at levels less than 10, they have an even higher impact than a single unit. And so when we start to look at then, if you look at a level of 10 or so, you see this sort of linear relationship. But at levels less than 10, it tends to have this logarithmic relationship. And so not only do we want to reduce from a population and for individuals a level of lead below 10, we want to actually even reduce it below that because it has such an impact on a population basis at levels less than 10. Let's see, Nicole says, can you clarify the role of ZPP in cases of lead poisoning? I always get confused on that. Thanks, Nicole. Thanks for the question. So the issue, historically, ZPP levels were used particularly to try and understand chronic exposure, because in an acute level, so you could have a scenario where a kid swallows a lead weight or gets into some sort of lead-based thing that day, their ZPP will not be elevated. And so if you were to order a ZPP that day on a kid who swallows a lead weight, should have a normal ZPP. However, in a kid who either has swallowed a lead weight and shows up 30 days later, or they're getting daily exposure to lead paint, lead fumes, things like that, they will have an elevated ZPP over the course of weeks. What we found is that it can be confusing for one, because we don't see as people who are working with lead as much, and not all the hospitals have ZPP readily available. And so the first thing we'll ask is just get a lead level, and then if we're looking for other indices of chronic exposure, we can look at things like, are they anemic or not? And then ZPP can fall into that. But that's the difference, is really trying to determine as we're going through, when we have somebody who has an elevated lead level, trying to figure out, is this a one-time, this just started today because they swallowed a lead weight, or has this been going on for weeks? And if it's been going on for weeks, things like lead lines, ZPP, and so forth will help us understand that, which will take us to the next step, which is trying to identify what that is so we can get it removed. So thanks for that question. Sure. Yeah. Let's see. This is another one. So there are a number of these studies that you will find that as blood lead levels go on for a period of time, you see this decrease in measurement of developmental ability and so forth. So that's why, from a public health basis, we want to get these levels as low as possible. Some people may have heard this. It's been a couple of years now, but if you've ever looked at, you'll probably look at this a different way now, but if you look at the Sherwin-Williams sort of marking logo, they want to cover the earth, right? And so they had a lead settlement with California in about, I guess, 13 years ago now, where they received $1.1 billion, which was to go to things like our lead prevention programs in public health, which 1.1 billion seems like a lot of money. But if you look at the impact of what we anticipate lead to be, it's at least on the order of about 11 billion a year. And then as we remove these things, the medical costs can be somewhere between, now up to, 300 billion a year. And so the idea that, 1.1 is good, but, we need a lot more. Part of the reason is when we look at cover the earth, we find that, in lead, particularly in a residential setting, or paint in a residential setting, which contains lead, can really get kids exposed for a long period of time. I put this slide in here because we often get asked about Flint and Flint, Michigan. So for those of you who may have followed this, a few years now, I guess almost a decade ago, there was a change. So the city in Flint was using one place to get their water, and then they changed to another place. And in that change, there was a difference in acidity with regards to the pipe that was being used. And so that meant that more, or not the pipe being used, there's a change in the acidity of the water. And what that allowed for was lead to be leached from the water. And so what we saw was there were kids who went from doubling of their detectable lead levels over that period of time. And so, let's see, I guess I got lost. And so what you saw were kids who had a blood lead level of either non-detectable or at levels in the ones, twos, and threes, who then moved to levels of four, fives, and sixes. And so what that means for, if you go back and look at that population curve that I had just shown you, you can see what that would do to a population impact of as you start to increase blood lead levels on a population, you have a number of effects of just increase affecting population IQ and developmental scores and a number of sort of neurologic outcomes for that. So how does lead get in? How does water get into the home? So what you have generally in a municipal setting, in a place like here in Northern California, we have water that's brought from the Hetch Hetchy and some of the sort of way north of California. That's brought down in non-leaded lines. But what happens is once these non-leaded lines get connected to a home, you can have lead all the way through these homes. And so when you're asking about, let's say, lead in someone's drinking water, and you're asking, do they get municipal water? The next question is, how do they get water from their blood, from the municipal source into their home? And you'll find that people who, let's say, don't own their home or don't have much say into how the piping is and so forth in their home, are just at the mercy of whomever owns that. And so you can have lead at the connector, and you can also have lead in the plumbing within the home, depending on when the home was there. And so you can test for water. You can test the water for things like lead. We found it in the solder that's in plumbing. You can find it in the faucets, particularly older faucets and things like that. And so it can be. It's not a large source compared to things like a lead weight and things like that, but can be a source of lead. So this is that slide I was looking for, was to give you an idea of what happened in that blood lead level in Flint. And so what they saw was, as they went and changed water sources, they found that they increased the number of kids who had a blood lead level of 5 doubled from 2.5% to 5%. And so if you're looking at from a population basis, that impacts that population. So now we'll move on to some recommendations. So the first part on lead is just to understand, what are we trying to do in our sort of primary, secondary, and tertiary prevention. And so oftentimes we sort of jump to this screening portion of lead, which is not my favorite. It's what we have to do, but it's not my favorite. And the reason why it's not my favorite is here we're just kind of using kids as little biomonitors, right? They're going and getting lead, they're getting in their blood, and then we're poking them to get blood out of them to figure out if they're eating lead. So it's not ideal, but it's what we have. In an ideal world, we would figure out where all the lead is, particularly in, let's say, in a residential setting, and get all that removed so a kid never gets exposed to it. The issue is that tends to be very expensive. And so when people move into a new home, the home may get painted, but it never got actually removed. And so if you ever if you move in, if you ever look at the paint of a house that has lead, that's older and has lead in it, you can look at the different flakes and see that there are many layers. And let's say the most recent layers don't have lead in it, but the older layers do. So that would be an ideal world, is that we're just able to eliminate the lead. But what we spend time doing is screening kids, because we know they're getting exposed. And the third part is then we start to just deal with preventing the outcomes of what we do when we have kids who have lead exposures. So in the tertiary prevention removal realm, is we've talked about this, but to summarize, we want to do some gut decontamination. We want to get all that stuff out. We want to put them in a lead-free environment. We have admitted kids and gotten their hospitalization paid for because we weren't able to get them into a lead-free environment. And so it usually takes a couple days to make sure that home, wherever they're returning to, and it doesn't necessarily have to be an expensive thing. Let's say you have flaking paint, you can cover that with duct tape, right? It's not ideal, but you can cover that flaking paint and things like that. And then we'll do things like chelation. And then I've got oral and IV chelation at these higher levels. Most hospitals don't carry the IV chelation anymore because of cost. So this just gives you a sense. So in 2000, I need to update these slides. But in 2008, a full chelation package for a kid cost $464. Then by 2014, it was $26,000, which is why most hospitals don't carry this anymore. So we ended up back then writing a letter to Congress to say, hey, this stuff is pretty expensive, and we're not able to find it for some of our patients. And what ended up happening was if some of you may remember this guy who's called the Pharma Bro, it wasn't him, but some of his colleagues who had purchased the single company that made these things and then made them really expensive. A lot of them ended up going to jail because of this, but it hasn't resulted in decreased costs. And so what we end up doing is using the alternative, which is this thing called oral succimer, as opposed to IV calcium EDTA. And so you need to ask your hospital if you're dealing with this, and we can help with this, if they even have calcium EDTA. Sometimes what we will do is do a swap, because some hospitals will have an agreement where they might stock it and they will provide it to their sister hospital and then agree to pay for the replacement. And so we do that up here in Northern California sometimes. This is a nice study that looked at a nice study from the sort of succimer perspective of kids who were exposed to really high levels of lead. So this was in Nigeria, where there were artisanal gold miners who would spend part of their day trying to sort through soil to find gold, but that soil was pretty high on lead. The same tools they were using to sort through the soil for gold would also be used to grind up corn for food. And so what they had were this influx of kids who had these blood lead levels pretty high. I mean, they had 15 kids present with a blood lead level above 200, which is, super high. This is seizing and encephalopathic and things like that. And they didn't have the really expensive calcium EDTA, but what they did have was succimer. And so they were able to give oral succimer to get these kids reduced, to get their blood lead levels reduced. Oops, sorry. And so we rely on some of this when we're talking about the use of an oral medication in kids who are really sick. Ideally, if we had, intravenous, we'll use it, but sometimes we don't, so we'll use the oral. So that's just highlighting that. I'm going to pause because I think I've taken you guys a little bit over. I know we go over a little bit, but I'm going to stop and see if you have any thoughts, questions, or otherwise, and take some questions from you all. And yeah. Questions, concerns. I don't know if Nicole ever made it from LA County Department of Public Health. Does anybody know? Oh, Nicole, you there? All right, great. I'm glad you guys get to see her. So I guess, Nicole, you're in there with some of the residents, so they get to at least see you as a resource. So all the things I was talking about with public health, Nicole would be a great resource if you have a kid with lead. Nicole, I don't know if you're able to unmute or anything, but as long as you guys are able to see her and get to know that you have a local resource there. Maybe not.
Hello, can you hear me?
Yeah, I can hear you.
Okay, great. Hello, everyone. I'm the nurse manager for the Los Angeles County Childhood Lead Poisoning Prevention Program. And just to give you a little bit of context, thank you, of what we provide in our program. Just to go over a little bit, I'm going to go a little fast. We have our environmental health specialist here, our chief, Mercury. She's also with me to give a little bit of information about how our program operates. Also, just to let you know that we do have public health nurses in our program that do go out to homes. We usually go out to homes with lead levels that are above 15.5. That is a Venus. So our gold standard is a Venus, not a capillary. If you do a capillary, then you're going to have to retest them again. So you're going to have to bring that child in twice to have them poked, which is not the ideal situation for a parent. If they're 14.5 and above, they will be assigned a public health nurse. That public health nurse will contact the family. They will get as much information as possible. They will also try to schedule a home visit to try to figure out what the lead level exposure is. They will work with that family until the lead level goes below 3.5, 3.4. So they're with those children for a minimum of a year. So get to know them very well. In that same token, the environmental health specialist will go out as well, and they will take paint soil samples as well to figure out exactly what the exposure is. What I added, I went with that.
So aside from the paint samples, we also take dust and soil samples, water samples from tap in the kitchen. We take about 2 draws from tap. We ask the families to not use the water to ensure that we get the concentration of lead from the tap. Once we find the source of the lead exposure, we issue abatement orders to the property owners at rental properties to make sure that they eliminate the lead exposure. And we work with the owners through our enforcement procedures to make them comply with our orders.
Any questions? You can always reach out to us through LA County Department of Public Health, the Lead Poisoning Prevention Program. We have a 1-800 number. Somebody is always there to answer. And if we're not able to answer, please leave a message. We'll get back to you. If you have questions, you can always ask the nurses who are on duty that day for any type of information you'd like.
Apart from a venous lead level, is there any other lab or order that we should put in, any specific consults?
We always say hemoglobin hematocrit if you're going to do a lead, because that way they get
That we would probably,
certification.
we would probably take it at the CDC anyways.
So, okay, so then we would have everything we need within that one panel. So
Okay.
that'd be perfect.
And then just reach out to LA Public Health.
Yeah, if you have
Okay.
additional questions or you need assistance on how to properly case manage that case.
Yeah,
Especially the higher lead levels, the ones that require the chelation, they're kind of, they can be kind of difficult sometimes because not only are you dealing with the lead, but you're probably dealing with a social economic issue because they're probably living in a home that is older, or maybe it's an immigrant, or maybe it's someone who's not quite up on what's going on in that home itself. So there's a lot of different things going on. So we are there to assist you with anything that you may need as far as questions or collaboration or anything like that.
Mhm.
Okay,
Thank you.
you're welcome.
Thanks a lot. Thanks a lot. I'm glad you guys were able to make it. I think it's a great resource to be able to have public health nurses for these cases. And so I can't tell you the number of times that we've gotten to work together. So with that, I'll stop and see if there are any questions, comments, concerns, and otherwise I guess I'll turn it back over to the PEDS chief.
Thank you so much, Dr. Durrani, and thank you so much, Ms. Nicole and your team for coming out. And I think we hear this a lot in clinic where we test for lead more often than in the inpatient setting. So I'll try and make sure we can find a way to disseminate everything you shared to the rest of the residents. But thank you everyone else and all the applicants and the residents for making time for noon conference today. And the slides will be uploaded into our deck for reference. And if you ever wanted to reach out to Dr. Nolan from yesterday or Dr. Durrani, they were going to be available. Thank you. Have a good afternoon, everyone.